Hello, I'm Dr. Olivier Rascol. I'm a neurologist. I am running the Expert Center for Parkinson's Disease in Toulouse in France, and I'm also running the French network for clinical research in Parkinson's disease in France. And at the University of Toulouse. I'm a clinical pharmacologist, and so I've been involved and interested in clinical trials and developing new medication for Parkinson's disease for many years. So there is one question, which is what is the consensus to define the wearing off problem in patients with Parkinson's disease? And at the moment there is no international consensus. The wearing off problem is known from very early after Levodopa was introduced to treat the patient with Parkinson's disease. But in fact, there are some questionnaires that patients and doctors can use to identify the wearing off problem, but without a common international definition. One of the problems for identifying the wearing off problem is that classically it is considered to be restricted to motor problems, and indeed a lot of patients, when they are on or off, when they are fluctuating, are identified because they get more tremor, they get again bradykinesia, they get more rigidity as if they were not receiving levodopa, as opposed to when they are on, which means when the drug is acting and effective at the level of the brain, and which is reducing the disability by improving tremor, slowness, and rigidity in movement. But apart from these motor symptoms, we learn later on that there are also a number of non-motor symptoms which are fluctuating in response to the change in the efficacy of levodopa across the day. There have been different questionnaires or scales that has been developed in the past to try to better capture and identify these fluctuations. And we have the wearing off questionnaire, which is a questionnaire addressed to the patients. There are also approaches depending on the doctor and investigator questioning the patient. In the past, these two approaches have been tested, and the patients are more sensitive and more accurate in detecting the fluctuation than the doctors, as long as they have been informed and they understand what is the problem. So the issue of the non-motor symptom in Parkinson's disease has really been acknowledged, and we realize how important it is for the patient quality of life only 10 years ago. And there is a very large variety of non-motor symptoms which are related to Parkinson's disease. There can be cognitive impairments, they can be mood and anxiety problems, they can be sensory problems and pain, they can be autonomic dysfunction, dysregulation, and a number of other non-motor symptoms. So some of these do fluctuate in response to levodopa, not all of them. Of course, for example, when a patient has cognitive impairment, it might be related to dementia, and it's not necessarily modified by levodopa. But in a number of patients, for example, the level of anxiety, which is very common in Parkinson's disease, is dramatically changing depending if they are on or off in response to levodopa. So again, it has been clearly identified that the quality of life of the patient is influenced by these non-motor symptoms, and that it is for that reason important to identify them properly, because they can be improved by a specific treatment strategy which is targeting at reducing the fluctuation of levodopa plasma level to get a more stable response, motor and non-motor, during the day. Another issue with the wearing off problem is that at the early stage of the disease, when levodopa has been prescribed only for a short period of time, it's not entirely sure if there are true fluctuations, or if these fluctuations are existing, the difference between the condition of the patient in the off and in the on is so small that it is very difficult to detect it even for the patient. But once the disease is progressing and the underlying neurodegenerative process is worsening, then the difference between the condition of the patient in the on and in the off stage is become much more different. And after 2 to 5 years of treatment, then the patients clearly feel the need that we should adjust the treatment to minimize this fluctuation. In general, they start with the TID regimen. They take Levodopa in the morning, at lunch, and in the evening. And with this TID regimen at the beginning, their condition is relatively stable. After a few years, well, in the end of the morning, before the lunch time intake of Levodopa, they start to feel again tremor, motor disability, and non-motor symptoms, and the same in the afternoon. And the more the disease is progressing, the more severe the on-off is developing, with very abrupt change and not any more progressive change between the off to the on and vice versa, and also with the duration in response to a given dose of Levodopa being shorter and shorter, requiring to add more and more Levodopa intake during the day to try to get a stable patient condition over the day. So one of the first studies that have been testing the wearing off questionnaire, the WOQ-19, which is addressed and fulfilled by the patients, studied about 300 patients with Parkinson's disease. And this is in this questionnaire, and in that study using this questionnaire, that it was shown that the patients were more accurate in identifying the problem than doctors asking for the question and for the problem. So again, we not use very frequently this kind of questionnaire in clinical routine, but certainly it would help in identifying earlier and more accurately the wearing off problem in our patients. Now, another issue is to, once you have identified the problem, to understand what are the reasons and how to adapt the treatment to try to minimize the cause of the wearing off problem. And there are a number of aspects which are simple to understand and are driving the way we adjust the treatment to fight with the wearing off problem. The first thing is that Levodopa has a very short elimination half-life. So in the early stage, when you give Levodopa 3 times daily, the concentration of Levodopa in the plasma are fluctuating. But we believe that at the level of the brain, there is still some capacity of buffering for this plasma fluctuation so that the response remains stable. But over time, the capacity of buffering of the brain are less and less effective, and then the Levodopa concentration are fluctuating in the brain on the same mode as they are fluctuating in the plasma. And then the neurons are exposed to high and low level of Levodopa, and in response to these changes in concentration, the motor outcome, the command for the movement and for the non-motor symptoms, is also fluctuating, being improved when the concentrations are high and being worsened when the concentrations are too low. Another way to try to address the problem of the wearing off would be to prevent the neurodegenerative process to worsen over time, which we call generally neuroprotection, because it is one of the contributing factors of the wearing off. In the early stage, when there is not much degeneration in the brain, the wearing off problem is mild or non-existing, and in the advanced stage, when there is much more neurodegeneration in the brain, the fluctuations are much more severe. But in fact, at the moment, we do not have any treatment which has shown to positively reduce the progression or the worsening of Parkinson's disease over time. There have been 2 studies with Levodopa showing that, in fact, when patients receive levodopa for several months, and when we calculate the level of disability based on the Unified Parkinson's Disease Rating Scale, well, those on placebo or those receiving levodopa, as long as the symptomatic benefit of the drug has been washed out, are not very different. And this illustrates that at the moment our understanding of the mechanism of action of levodopa is that the drug has no impact on disease progression. It's not only levodopa which has no impact on the Parkinson's disease progression and worsening over time. In fact, this observation, as far as we understand the effect of the drugs which are on the market, is applying to any compound. There has been studies involving dopamine agonists, involved MAO-B inhibitors. They have been looking at hundreds and thousands of patients over years, and the overall conclusion is that none of these drugs has definitely proven that it had a positive impact slowing down the progression of Parkinson's disease. And there are other approaches, including non-pharmacological intervention like physical exercise, but also nutrition supplements like CoQ10, which in theory might have some benefit on the functioning of the neuron to protect them from dying, but the available evidence from clinical trials show that no benefit has ever been 100% demonstrated. There are a number of drugs that can be combined with levodopa to reduce the ring-off problem, and this is because they have by themselves a longer duration of effect because of a longer elimination half-life, or because they are enhancing and prolonging the elimination half-life of levodopa itself. And among these drugs there are the dopamine agonists, and they include pramipexole, ropinirole, and rotigotide. There are MAO-B inhibitors, and these include selegiline and rosagiline. And there are also the COMT inhibitors, which include entacapone, tolcapone, and opicapone. The dopamine agonists are symptomatic dopaminergic medication acting directly on the receptors, and they have a longer elimination half-life than levodopa, and when they are combined with levodopa, they reduce the time the patients spend off during the day. So this is one avenue, and it has been consistently shown in clinical trials, and so they are considered as efficacious and clinically useful. The question with the agonist is that they have their disadvantages in terms of tolerability, and mainly because in some patients they can induce daytime somnolence, and they can also induce abnormal behaviors with impulsivity. And so the doctor and the patient has to balance the benefit on the off problem as opposed to the risk of such adverse event. For MAO-B inhibitors, again, there are clinical trials showing that the total amount of time spent off during the day by the patients when they receive an MAO-B inhibitor is reduced, and this about by 50 minutes per day above the placebo response. And for the COMT inhibitors, there are also trials documenting the reduction in time spent off when patients receive a COMT inhibitor in combination with levodopa, and that this is significantly a greater reduction as opposed to the placebo effect. Among the different COMT inhibitors, the efficacy might be slightly different. Entacapone is the oldest one, the most commonly used. The effect is about 50 minutes per day in reducing time spent off. Tolcapone might be a little bit more efficacious, over an hour and 10-20 minutes in time spent off. The problem with tolcapone is that at the moment it is only second-line treatment because of liver toxicity, because there have been hepatitis, drug-induced hepatitis reported with tolcapone. And this is why it's interesting to get another COMT inhibitor like opicapone, which at the moment have proven to be safe regarding liver toxicity, and in clinical trials might induce a slightly greater benefit than entacapone in terms of reduction in time spent off. Opicapone is the most recently developed COMT inhibitors for the treatment of motor and non-motor fluctuation in Parkinson's disease. And in the phase 3 development program, there have been several studies comparing different doses of opicapone versus placebo. And in one of these studies, entacapone was chosen as the active comparator. And overall, the conclusion of these studies are that opicapone at the dose of 50 milligrams per day is superior to placebo and is non-inferior to entacapone. And when one looks carefully to the secondary endpoints of the study, there are reasons to believe that there might be some extra benefit with opicapone as opposed to entacapone in the amount of time spent off by the patients when randomized to opicapone over to entacapone, although head-to-head comparison did not formally demonstrate statistical superiority. Of course, for the future, the challenge to better manage patients with Parkinson's disease is to understand the cause or the different causes of the disease, to identify targets that can be suitable for new medication to block the process or even to prevent it. So this is the future of neuroprotection. There are many new exciting targets and compounds and studies ongoing at the moment, but it's very hard to say presently if which one is going to be the one which is curing Parkinson's disease. On the other hand, until we get this cure of Parkinson's disease, we can still work on delivering levodopa in a better way or developing a new symptomatic anti-Parkinson medication to provide a better response to the patients. So at the moment, there are ways to extend the delivery of levodopa from new formulation with extended release formulation or new mode of delivery, which could be subcutaneous continuous infusion, which can be intranasal inhalation for a very short but rapid effect. So these are different approaches with levodopa. Similarly, there are other compounds which are not necessarily targeting at dopamine, but may be positively influencing the way the motor circuitry and the non-motor loops in the brain are functioning. And there are serotonin medication, there are glutamate medication that are also in the pipeline, among others, and we hope that these drugs will help the patients and the doctors to reduce the problem of the motor and the non-motor fluctuations, which are the consequence of the present insufficiency of levodopa, mainly because of its pharmacokinetics. Thank you very much. If I want to summarize what we just covered, it's important to emphasize that the wearing off problem is a very common problem in patients with Parkinson's disease. It has a negative impact on patients' quality of life. It is frequently under-recognized, and it's not only involving the motor parts of the phenomenology, but the non-motor symptoms of the patients are also fluctuating. In terms of therapeutic management, of course, if in the future we can cure Parkinson's disease, that might be the complete solution, but we are still far from that goal. And in between, we need to adjust the symptomatic medications that are available, and this is a combination of levodopa with the disadvantage of its short elimination half-life, and then its short duration of action, which is one of the main reasons why the wearing off problem is emerging over time. And this is why we also combine levodopa with other compounds like the dopamine agonists, like the MAO-B inhibitors, and like the COMT inhibitors. And among the COMT inhibitors, the most recently marketed is opicapone.